Dr. Poon gave an excellent talk, and I'm actually going to reiterate some of the things that were discussed there. I think it's worthwhile doing. At the end of her talk, I'm like, ooh, I should just go to my last slide, but maybe after chatting with some of you, we'll go through the whole process and talking about what is currently being, the mainstay of therapy, as well as some of what's new on the horizon, which really involves a close interaction with your heart failure cardiologist, to be honest. So my only disclosure slide is I want to thank a lot of the slides actually I stole from my colleagues who give these talks all the time. I give a lot of mechanical support talks, so Drs. Ross and McDonald. I don't have money from anywhere other than CIHR grants. No one pays me for anything except what I earn by myself. So heart failure is an epidemic, as we know, right? So we have at least 1 million Canadians that are living with heart failure, and there's about 50,000 cases that are being diagnosed every year. And the reality is, if you're over the age of 40, you have a 1 in 5 chance of actually developing heart failure in your lifetime. So this is actually very, very scary. And if we look at the projected numbers over the next 20 years, you can see that the prevalence is going to increase by 20%, 25%. And when you look at the actual medical costs, they're going to go up to $77 billion, which is really quite scary. And this is US dollars, and ours is not that far behind. Now, we've talked a little bit about HFrEF and what underpins it, and it's really the overactivation of the renin-angiotensin-aldosterone system and the sympathetic nervous system. And we've spent, I think, a fair amount of time talking about beta blockers affecting the CNS, the RAS inhibitors, which are the ACE inhibitors, the ARBs, and the mineralocorticoid receptor antagonists, and how we're actually monitoring the natriuretic peptides for looking at this system. And really the first step in anything is looking at triple therapy. Guideline targeted therapy is really the mainstay. And sometimes we lose track of that, and even when patients come in, we do really have to focus on that as well as adding the MRA. And that takes time. All of it is about starting low, going slow. A lot of patients have issues with their blood pressure, and if they're on drugs that are not guideline directed, to be honest, I stop them and restart on guideline directed therapies. And because it gives us an opportunity. Every medication we start will cause some degree of change in blood pressure. So we use that opportunity of having a higher blood pressure to really put them on the drugs that will be helpful when they have heart failure. And I'm specifically going to focus on HFrEF because that's still, even though if we look at the numbers, HFpEF is growing as our population is growing, but it's really where most of the evidence lies. So what's next? And Dr. Poon has spoken a bit about that, and that's the drug LCZ696, also known as Entresto. God, Mike has really good slides, huh? Look at this. So what we know is we can suppress the renin-angiotensin system with ARBs and ARBs, but with a combination drug of valsartan with sacubitril, we're able to then go after the natriuretic peptide and really go after both affecting and in a positive way affecting and blocking the detrimental effects of the RAS system, but also enhancing the beneficial effects of the natriuretic peptides. And the data is quite strong. We know that there is a huge reduction that actually shows up within the first 30 days in terms of heart failure hospitalizations. Now, I'm not going to go into every single clinical trial on that because you're going to just glaze over, and that's not really the point. But really understanding that the effect of a drug like Entresto, because it's just easier to say than LCZ696, it actually doubles the effect on cardiovascular death, and that's on top of being on an ARB or an ACE inhibitor. So this is actually quite a striking slide, I think, and really beats home the message that really it's really important to think about being able to transition patients from either an ARB or an ACE to a drug like Entresto. Now, this has been studied before, the use of niprolysin inhibitors. This is not new. So we've had things like imiprilat, which is again combined but with an ACE inhibitor, but it was only with a modest effect in blood pressure or heart failure. But the problem was that there was an unacceptably high incidence of angioedema, and this is where we actually had moved away from imiprilat, and we've had a lot of success with Entresto. But what are the kinds of things that you have to think about? And yes, we would love to have a collaborative shared care with you with respect to these patients. So the things to think about is, are your patients already on maximally tolerated medical therapy? You don't start and start starting drugs. Your first line is still a beta blocker, an ACE or an ARB, depending on side effect profile, MRA, and then you think about an ARNI. And what is their average blood pressure? Do they have any allergies? Do they have drug coverages? The thing is, this is not a cheap drug, and if they're not on disability or over the age of 65, they're going to pay upwards of $1,000 per month for this drug, and that's a high cost, even though that the cardiovascular benefits are quite high. Not everyone can afford this. So it is about having a really good discussion with your patients around that. And then any issues with potassium in the past. It's interesting that I think, and it's not well recognized, is that there are a number of patients who actually have hyperkalemia once they get switched from a ACE or ARB to an ARNI. And it's really important that you monitor, if you're going to take this on, you're going to monitor the potassium over the next subsequent 2 weeks. That's sort of what I do. I do reduce the dose. There's sort of equivalent doses that are out there, and if they're on an ACE inhibitor, it does require a 36-hour washout period. We actually provide letters to the pharmacist as well as to the family doctor from our clinic at UHN to educate around that fact and and actually have a starting point for the patient on their letter to say, okay, you're going to stop your ACE inhibitor today and you're going to start the ARNI on this day, so that it's clear. And despite that, you'd be surprised. There's still patients that are taking both, and you wonder why their kidneys are still functioning. So it's very important to educate your patients as well as having good crosstalk with and sometimes with your pharmacist. So we do have a form that is easy, that's printable, that we just give to the pharmacist as well. And the next step is to think about Ivabradine, which is the other new hot topic that's on the market, and that is really looking at patients who have been discharged and then looking at their heart rate on discharge and how it relates to risk mortality. And this is just to illustrate, on the one side we have unadjusted odds ratio on the left, and on the right we have the adjusted odds ratio. And it's pretty clear that the higher the heart rate is at discharge, that the risk of death is quite high. So it is worthwhile trying to aim for a target that's between 50 and 60. I usually say 55 to 65. It's around, the importance is to get the heart rate in the 60s. And so we use Ivabradine, which affects the sinus node. And in the SHIFT trial, which is really the seminal trial that looked at this, these patients were actually well treated. 90% were on a beta blocker, 91% were on an ACE or an ARB, and 60% were on aldactone, and it was Ivabradine versus placebo. And very quickly you see that the primary cardiovascular endpoint shows, as Dr. Poon alluded to, an 18% reduction in the primary endpoint. And this is mainly driven by a reduction in hospital admissions and worsening heart failure, as well as deaths due to heart failure. Interestingly enough, when you look at the SHIFT trial and how it actually impacts heart function, that is ejection fraction, and you look at the other clinical trials that have looked at changes in heart rate, so those other trials are called Signify and Beautiful. Who came up with these names, who knows? So the SHIFT trial shows a really nice increase in the ejection fraction of 29% from baseline, as well as a reduction in mortality, a primary endpoint being cardiovascular death or heart failure hospitalization of about 5% reduction. So not only does it reduce death, but it also helps to improve ejection fraction. I'm not sure that we understand the mechanism of that. Time will tell. So before you start Ivabradine, what kind of questions should you ask? And these are the things that we ask. Are your patients on maximally tolerated beta blockade? It's very important. There's no point to start Ivabradine if you're on half of the maximal dose of Coreg or half the maximal dose. You haven't really done due diligence there. And what is their average heart rate? And do they have drug coverage? This one is not covered. There is an LU code for Entresto, which is 497. We've alluded to it. We know these numbers. Sometimes we don't know what the LU codes for some of the other things are, but for Entresto 497, this one doesn't have it. So it's just as expensive. So even though it may be important to start your patients of it, some of them cannot afford it. And if we look at, this has shown up a few times today, what is actually recommended by the Canadian Cardiovascular Heart Failure Guidelines, you see that first you're starting them on an ACE or an ARB versus a beta blocker and an MRA. You reassess symptoms, and then you see, according to their functional class, when to add these next series levels of drugs. So it's, again, class 2 to 4 symptoms, a heart rate greater than 70 versus a heart rate less than 70, and then you think about how to do that, and then you have to reassess symptoms. And if they're still symptomatic at that point, then they need actually a referral to a center, or even before that, actually, referral to a center that can offer advanced therapies. So the first session today was around diabetes and how it is an epidemic in the new drugs that are out there. Not many cardiologists, to be honest, are really comfortable in looking at SGLT2 inhibitors and how to actually prescribe them. It's just a comfort level, not necessarily anything else. And it's not surprising that you can get a reduction. At least 68% of people that are over the age of 65 with diabetes die of heart disease. So it's a big problem in our growing population, probably relates to the degree of obesity that we have as well. If you walk down the street, it always surprises me, the BMI, the average BMI of the Canadian population, it just seems to be growing. And one of the astounding first clinical trials that was done was with EMPA-REG trial, which actually did show a quite dramatic reduction, not only in all-cause mortality, but death due to cardiovascular death, as well as hospitalizations due to heart failure. So that kind of takes us to what's in the wings. What is the future? So there has been some data that's been published on other drugs that can actually optimize the MRA therapy in diabetes and chronic kidney disease and heart failure. And that's been published, but it's not actually been a very strong evidence to do that. There is a current trial that is still enrolling. We're close to 1,000 patients now. It's called the Sodium Heart Failure Trial, and it's really understanding the basis of the sodium paradigm. And there is actually some proponents of the fact that maybe we're being too rigorous with sodium, and maybe low sodium is not really the key. Looking at Entresto and HFpEF, the Paragon Heart Failure Trial, and there are tons and tons of SGLT2 inhibitor trials that are coming out, as well as in HFpEF. And vericiguat is actually now being enrolling for looking for soluble guanylate cyclase stimulators in the Victoria trial. So there's lots of trials that are coming up, and we just have to wait and see how they will add or change our medical therapy for our patients. But what else? This is where it gets interesting. It's the world of the machines, and as the director of the Mechanical Support Program, I can tell you that there's still a lot that we can do for patients. We have on the far right a representation of something called the CardioMEMS. It is actually inserted into the pulmonary artery and allows us to really, really focus in on what are the pulmonary pressures so that we can titrate medical therapy to an exquisite level that cannot be based on physical exam. We all have patients we can't examine. No matter what we do, we look at the neck and God knows where that JVP is, and there's a lot of guesswork, right? So, and they don't all have to be this big at the neck, but they can certainly be difficult to examine. And the CardioMEMS is now in clinical trials here, and we've been using it at the Toronto General Hospital through our heart failure program to monitor PA systolic pressures, and it's been very helpful. The next series of pictures are actually alluding to mechanical assist devices or ventricular assist devices called VADs. This is where we are going. This is how in patients who are not candidates for transplant, one is age, another is comorbidities like peripheral vascular disease, the associated complications of diabetes. There are certain issues that make our patients who we see that are in end-stage heart failure and they're not candidates for a transplant. The ventricular assist device has really changed the avenue. It's just that it's incredibly expensive. The device itself costs $75,000, and an average stay at the implant is $150,000. So it actually is quite an expensive therapy. But what is really good about this therapy is that patients actually now go from, if you can imagine, a cardiac output of 1.5 liters per minute to 5 liters per minute. They can get good quality of life. They can exercise. In fact, we had one patient who was walking 25 kilometers per week. Who in this room walks 25 kilometers per week? There'd probably be one person who exercises that well or has the time. So it allows us the ability to rehabilitate our patients to a level that has not been attainable before. And we have now in our own program, we have a patient who's had it for 9 years. And actually worldwide, we're up probably closer to 13 to 15 years with the same machine. There are issues with it, and it has to go through a rigorous protocol. But if you have patients that are really advancing in their heart failure, I would say to you, do not wait, but rather refer early so they can be assessed and they haven't missed that opportunity. So in summary, guideline-directed medical therapy is the key. There are new heart failure therapies that are out there that both Dr. Poon and I have alluded to. And that being Entresto versus Ivabradine, and it's really symptom status that actually will guide the need for additions to the standard therapy, and really device therapies versus transplantation are the final destination, and they come with their own baggage, and they're not as straightforward as people think. They're not the nirvana, and they have their own issues. Thank you.